So you can see that 62-year-old woman has attended the diabetic clinic for review. Just a moment. And she was diagnosed with type 2 diabetes 5 years back, and has until recently been well managed with metformin 1 gram and glyclazide, which is a sulfonylurea glyclazide 160 mg once daily. Usually it is 80 mg or 160 mg or 40 mg we do use glyclazide. Now no, it is glyclazide. This one we are talking. Oh, you are coming now. Okay. So, yes. So, the question is basically in the latest HB1C 62, which is actually high. The consultant has advised commencing a medication to increase the levels of incretins. So, who is an incretin increaser basically? So, dapagliflozin, glimepiride, liraglutide, this one, pioglitazone, and sitagliptin. The answer is sitagliptin. You are correct. So let's discuss the other mode of actions of all the medication. Dapagliflozin, how does it work?
It is
SGLT2 inhibitor. And where does SGLT2 remains in body? It is in the kidney, proximal convoluted tubule. There is also one SGLT1, and that is in the intestine.
dependent.
Yes, that is also in the intestine.
Abu क्या बोल रहे हो?
3.5 hours plus
Some sound. Okay. What about glimepiride? It is sulfonylurea. It is a second generation sulfonylurea. So less, and we all use these days. Liraglutide. How does it work?
Liraglutide is exenatide. I think exenatide liraglutide.
So it is GLP-1 mimetic. Actually, GLP-1 mimetic, and basically, and then pioglitazone. What is this?
PT paroxysmal partner gamma receptor.
It's TJD, basically. Thiazolidinedione. So how does it act? Why we should use pioglitazone, or when we should not use pioglitazone? These two things we need to understand. So we have to use yes, insulin sensitivity. It increases the insulin. Yes.
No, actually it releases insulin. Sir.
Yes.
It releases insulin. It is present in muscles and.
No. It doesn't release insulin. Insulin is released by two groups actually. Insulin is released by either the group of sulfonylurea or somebody else, which are not very much used. Incretins, okay. Anybody else? Anything? Any other medication? Any other medication?
Bromocriptine.
To some extent, okay. That's okay. What else? Which is actually used? Do you really much use bromocriptine much in clinical practice for this purpose? No. So repaglinide. Basically, glinides also do some burst of insulin secretion. So, and nowadays what is being said, basically the things which secretes insulin or which increases insulin secretion are not to be used. However, nice guideline for your part 1, that's a different thing, are to be used later. That's the current, all the guidelines are saying this. This is just for to preserve the beta cell reserve. Because if you whip the beta cell too much on the long run, because if somebody is taking sulfonylurea or glinides from a very beginning, 30 years, and he's taking it till he's 60, 65, a time will come that he will not have any beta cell reserve left. So that is the reason nowadays many newer guidelines are telling that start with DPP4 and SGLT2 inhibitors, and occasionally and metformin. These three combos nowadays things, and all the newer guidelines are saying this. But for your MRCP part 1, don't jump into this. It will be too early. Usually one thing, remember, for part 1 exam, all the questions, if you are sitting, suppose November diet, October, or diet 3 or diet 1 of next year, if you are sitting for that, all the questions are already been made. Questions are already been done. All the questions are usually set 1 year back. So don't jump into the last year's or latest year's guidelines. Usually they will come later. So previous guidelines, classical guidelines, try to follow. Coming to the sitagliptin, what it does? Sitagliptin is the DPP4 inhibitor. Okay, your answer was correct. One thing that I asked, when we should not use pioglitazone, what is the contraindication or caution for pioglitazone?
It causes prostate cancer.
It is causes
Prostate cancer, I guess. So in
uh,
case of benign prostatic hypertrophy, we are not supposed to use.
more importantly, pioglitazone can cause peripheral edema, water retention, fluid retention, weight gain, and
Cardiac failure.
yes, and
That is not.
worsening of heart failure. So anybody with low ejection fraction try to avoid pioglitazone. So that's why it is slowly falling out of favor. Now coming to another very nice new initiative which came in picture approximately 1920 onwards, that is non-diabetic role of DAPA, EMPA, that means the SGLT2 inhibitors. Non-diabetic role. Anybody?
It
Non-diabetic.
increases
Yes.
in chronic heart failure. It can use.
Yes. Yeah. So moderate. Suppose somebody is having a moderate zone EF, moderate reduction of LV ejection fraction. You can give dapagliflozin, even he is an euglycemic person. It can be given. However, again, this kind of questions, as per the NICE guidelines, you have to follow. Usually, keep in mind. But even in 2022, we are not expecting this kind of a questions. You will be probably getting these straightforward questions from the diabetes. Keep this thing in mind, however. Now, coming to one important discussion that we shall be discussing over here, I'm just erasing this thing over here a little bit. And this liraglutide, which is actually a GLP-1 mimicker. So, one thing that I want to, we usually do not use much in regular day-to-day practice, GLP-1 actually. So, NICE guidelines 2018 has a typical talk about this, where we should use GLP-1 mimickers or exenatide, liraglutide when we can use. Basically, you can use exenatide or liraglutide after the first two agents, metformin and sulfonylurea. After that, you can use, but only in specific condition. What are the condition? Where insulin is required, but insulin can't be prescribed. This kind of condition, insulin can't be prescribed. This is one area where liraglutide is indicated. Now, what is this area? Insulin is required, but insulin can't be prescribed. In case,
Obese patients.
no, obese, I am coming to that later. Obese, definitely, in obese also we can prescribe insulin unless and until it is too high. Definitely, we're correct over there. But majorly, if there's a legal implication to this, if the person is having a HGV license, HGV license is the level 2 license. That is the truck driver, bus driver, commercial vehicle driver. In them, because if you prescribe insulin, then they will lose their license. So that is the reason, first of all, you can't prescribe over there in that. Second category, definitely, if the patient doesn't want insulin, so refusal, then also you can't do that. Now coming to the obesity, that's definitely a factor. So where we can use, first of all, if BMI is more than 35, more than or equal to 35, exenatide is definitely a good choice. If BMI is less than 35, then also you can give exenatide, provided either of this, HGB license or refusal, either of this comes into the picture. Now the query is how long we can continue. Suppose insulin can be continued lifelong. What is the picture about exenatide? Now we have to check 3 monthly HbA1c, and if the patient on exenatide or liraglutide, if there is a drop in HbA1c of more than 1%, more than or equal to 1% in 6 months, or weight loss more than or equal to 3% in weight, then we can continue GLP-1 analog. Otherwise, we have to stop it. If neither of this, if one of this is achieved or both of this achieved, you continue. Neither of this achieved, you stop. And one major side effect of GLP-1 analog can be pancreatitis. So that is also, however, routine a lipase or amylase, it's not in the guidelines, but wise to do, and it is patient to patient, consultant to consultant over there. Routine is not over there written like that every 6 weeks, unless and until you are having some pancreatitis like symptoms. It is not there in the guidelines. It is patient to patient. Now again, coming back, if we just look at all the features of all the side effect profile of this one, of different OHA. Now, can you tell me the OHA um, which you can prescribe in pregnancy?
Glyphosate.
Which one?
Metformin and glyphosate.
Metformin. Yes.
Glyphosate also.
Some sulfonylurea. The safest is glibenclamide. Safest is glibenclamide. However, insulin is basically the thing. And again, there are certain things like preferably NICE guidelines, they suggest to go for which type of insulin, rapid insulin or NPH insulin. Yeah, either mixed, ectopit, these two. They have, or many authorities have a reservation regarding the long-acting insulins like detamir or glargine. However, recent FDA guidelines, recent means last few years actually, they are proposing for Lantus, that Lantus is safe. However, for your exam, go for these two classical variety of insulin only. That means the mixed and the ectopit. These two just go for as per the guideline. These are the things. Now coming to another query regarding the DPP-4 inhibitor, which one is the safest in kidney disease? In all the DPP-4 inhibitors, which one is the safest in the kidney disease? DPP-4 inhibitor means we have teneligliptin, we have sitagliptin, we have vildagliptin, we have liragliptin. Yeah, linagliptin, that is the safest. But again, sitagliptin, 2018 came to the point that 50 sitagliptin a day is safe. Now 19 onwards, people are saying 100 sitagliptin is safe, basically. So sita is also okay, but lina is the 0.1 first choice. That is, and that also depends on the CKD stages. Again, that will be too much intricate, not required. That much is not required for a part one discussion. Okay, coming to the liver issue, two particular medications is we can have some problem on liver, or some some kind of, because they're highly metabolized through liver, and their metabolism is very much based on liver. So particular OHAs who are have to be a little cautious in case of liver issue. Actually, all OHAs basically we have to be a little cautious. Definitely in failures and all those things, insulin is the safest. However, remember voglibose, that is the acarbose group, that can cause a little bit increase in the liver enzymes, and this glinide. These two, first of all, that have to be a little bit, we have to be a little bit worried or a little bit cautious. But again, complete hepatic failure, again insulin. If everything is stopped, insulin is the answer over there. Anyway, so this was a little bit discussion here, and now moving to